You can feel free to welcome our guests anytime, Nancy.
Okay, thank you. Hello, everyone, and welcome to Season 5, Episode 4 of this virtual lecture series hosted by Gateway Center of Excellence in Rural Health. The topic for today's session is physiotherapy, occupational therapy, and speech-language pathology in rural regions. My name is Nancy Simpson. I am Board Secretary for our organization. I want to acknowledge the land in which our office resides, the traditional territory of the Anishinaabe, Haudenosaunee, Neutral, and Wendat people. At this session, as the session will delve into the care and treatment on an individual level, it's also important to approach health on a community and environmental level. For this lecture, we have invited 3 healthcare practitioners who help to promote the rehabilitation and functionality when someone has been impacted by an injury, illness, or disability. It's my pleasure to introduce our 3 guest speakers. Dagny Haas is a registered physiotherapist with her Master of Clinical Science degree from the University of Western Ontario. She is a co-owner of a private physiotherapy clinic in Goderich where she treats a variety of injuries. Kathleen Gahagan is an occupational therapist and life care planner based in London, Ontario. She has worked with clients ranging from young school-age children to seniors, providing community-based care to individuals with a wide variety of health concerns, including musculoskeletal injury, brain injury, spinal cord injury, as well as mental health diagnoses. Lauren Summers of Bayfield has worked in both the public and private sector since 2019 as a registered speech-language pathologist alongside the First Nations population in remote northwestern Ontario. Her practice focuses on providing culturally sensitive and trauma-informed services for children and adults to improve functional communication and/or feeding and swallowing skills within their communities and beyond. To thank those who are regular attendees, we offer certificates at the end of each semester to those with perfect attendance to recognize your commitment to and involvement with this educational series. Throughout the lecture, we encourage those attending today to pose questions to the guest speakers. Please type your questions in the Q&A box and we'll attempt to address as many as time allows. The views expressed in this lecture may not necessarily reflect Gateway Center of Excellence in Rural Health's views or opinions, but we believe in providing a platform with a range of perspectives and thoughtful discussion. So let's start with you, Dagny, if you're all set to go.
Super. Thank you, Nancy. Share screen. Start broadcast. Thank you, Nancy. Thank you for the introduction. Thank you, Gateway, for having me here today to speak about physiotherapy. As Nancy said, I'm a physiotherapist working in Goderich in a private physiotherapy clinic. And I've got lots of pictures to go along with these slides to keep people's attention. There's a beautiful picture of our Goderich Harbor. So this is a picture of the clinic that I work in. It's a facility right in Goderich. We have 6 treatment rooms, a gym for people to work out in, and a waiting area. I've got a few pictures just to show you. You can see our front desk area with Kristen having a big smile. Walter, our skeleton, is always there to say hi when you first come in. Treatment rooms all pretty much look the same, and the gymnasium where people work out, although nobody looks like they're working very hard in that picture. Our staff consists of 5 physiotherapists, and there's a group of pictures. So we have pretty much everybody that works at the clinic in at least one of these pictures. So myself, Milena, Tim, Megan, and Val are physiotherapists that work with us here. We're lucky to have 2 physiotherapy assistants Kristen, and Abby. And we also have Jordan, who is a kinesiology graduate and is our tech wizard, as well as wizards in many other ways. And then Joy Miller is also an assistant at the clinic here. We're lucky at the clinic to mentor a variety of different students. So we do welcome students from Western doing their placement, which is usually a 7-week placement. They're physiotherapy students. We also do placements for physiotherapy assistant students as well. So from Lambton, Fanshawe, Mohawk College. And we also work with the local high schools doing co-ops for their students. And right now, this is Graham. He's with us right now for this semester. He's a great young guy, lovely to have around. So you may ask yourself, well, what is physiotherapy? Physiotherapy is a regulated healthcare profession. We're evidence-based. It's a university degree. So you've gone to school for an undergraduate degree, and then it's a post-grad education. And our goal really is to restore and maintain function. So trying to promote people's mobility and help with their independence as we all go through life. We try to maintain your independence by the use of movement and exercise. So who do we see in the clinic? Well, we see a variety of different conditions, and I've listed a number here. Orthopedic conditions, so that would mean muscle, bone, joint, ligament injuries. Concussions, so concussion rehab, whether it's sport, work-related, or you just fell at home and hit your head. Vestibular, so inner ear issues, as well as dizziness problems. Neurological disorders, so that could be something like Parkinson's disease or multiple sclerosis. Sports injuries, if you fell off your horse, running injury, anything to do with sport, we'll see. We also see surgical patients. So we'll see people before they have surgery to get them ready. We'll also see them post-surgical as well. We do the GLAD and BoneFit programs here. So GLAD is an arthritis program, an osteoarthritis program. It's a 6-week exercise program for people that have arthritis in their knees and their hips. BoneFit is an exercise program for people with osteoporosis. And other arthritises like rheumatoid arthritis, we also will treat at the clinic. So it's a big variety, it's a big scope of practice. What will happen at your first appointment? So you'll come in, you'll be introduced to your physiotherapist, you'll be taken into a room, and we initially talk to you. So we get to know you, find out about who you are, what your injury is, what your likes and dislikes are, what your goals are. And then we'll assess you. So we'll do a physical exam, find out what the injury is, talk to you about what we think is happening and where we see your treatment going, and trying to determine your goals and how they're going to meet with what we feel your treatment and your outcome will be. And our goal is always really to try to get people back to doing what what they really do enjoy doing. So treatment can mean a lot of things when it comes to physiotherapy, and I've listed a lot of things here. It can be manual therapy, can be exercise therapy, can be the use of modalities. We also do return to work programs or functional rehab. Taping can be part of that treatment. Gym sessions, education is always part of what we do pretty much every time we see somebody. The GLAD or the BoneFit programs, and we also do deep needling and acupuncture. So what is manual therapy? Well, manual therapy is a hands-on treatment. So usually it can be a mobilization of joints throughout the body or a manipulation of different joints in your body. Here we have a picture of Milena doing some traction on Janet's neck. She did not pull her head off, which was a big relief during the filming of this. We also do muscle releases. So that's using our hands to release the muscles that are tight or having some kind of issue around that area that we're working on. Exercise therapy is a big part of physiotherapy. So it can be either in the gym or or in the room. Usually there's some kind of home exercise program that takes place as well. It may not be strengthening exercises, it could be mobilization, so trying to keep an area moving and an area lubricated. So we have a picture of Abby and Val and Graham down at the bottom, and then there's Tim watching his client do some work in the gym. Taping can also be part of the therapy session. Sometimes people are just coming in to get taped. Sometimes it's part of the actual assessment or follow-up treatment that we're doing in the clinic itself. This is an ankle sprain, and it's being taped in order for her to get through her day. My son said to tell you all that taping is a really good way to, get your hair removed from your leg. Modalities, so we have a bunch of different modalities that we can use depending on what the injury is. Ultrasound machine, an interferential current, muscle stimulation, and we also use hot wax, especially on the hands. So an ultrasound machine can be used when there's swelling, if there's pain, if you're trying to get an area moving, so we can actually use it to heat up an area. Interferential current is used for pain control, and you can see this on the lady's back in that third picture at the bottom. She's having the interferential put on to help with back pain. Jordan, with his great pumpkin hat, is having a muscle stimulator put on his thigh by Milena. So the muscle stimulator helps a muscle to contract if there's some weakness there or it's post-surgery. Education, as I said, is really always part of what we do, whether it's educating the client on why we're doing the exercises, why they're having pain, why there's stiffness, why we foresee them taking this long to heal. We also will talk to them about any x-rays or reports that are coming in from their family doctor if they don't understand. Return to work program, that usually is with WSIB. So a work hardening program can also be with WSIB or a motor vehicle accident. And that usually entails, 2 or 3 days in the gym where people are strengthening certain body parts and also functionally becoming stronger to get ready to return to work so that they don't re-injure themselves when they actually get back to their regular routines. Deep needling, just a picture of some of the apparatus that we use for deep needling or acupuncture, which can be part of people's treatments if required and if the person wants to have that done. I do quite a lot of deep needling, not a lot of acupuncture. I find deep needling actually works much better than acupuncture does. Tele-rehab is still available at the clinic. Occasionally we use it. Sometimes people have moved away, but they still want to stay in contact, or if somebody's sick but would still like their appointment, they'll use tele-rehab. Certainly not what it was during COVID, but it is still definitely available and can work very well. Coverage, so payments come in many different forms. We are lucky in this area that we do have a partnership with the family health team for those clients that don't have any insurance. And bundled care is also available after knees, hips, and shoulder replacements. So that also helps people post-surgery. We work alongside the healthcare team in Goderich, and that's a real positive of a small town, is getting to know the other healthcare providers that are around. So we have the Alexander and Marine General Hospital close by, and then the Maitland Valley Health team. So we're very lucky to have a great team of professionals in the area to work with and, basically to talk to and utilize as needed. We also try to work with the other healthcare providers in the area as well. Goderich, as you know, is a small community, and there's a beautiful picture of our lovely square. Working in a small town is nice, and I really enjoy it because you do get to see different family members, and over time you see families change and grow, and as we all age, it's a privilege to get to know and see these people. We try to give back as much as possible. We have some really great organizations in town, certainly in the healthcare field. So the hospice and Gateway and the Hospital Foundation and Rotary, et cetera, are all terrific places that we try to support as much as possible. And I think the really funny thing in a small town is that people can't get away with doing what they're not supposed to do if your physiotherapist has told you that, because I'll probably see you running on the beach when I'm on the beach if you're not supposed to be, or doing something that you're not supposed to, which is always very amusing when that happens. So thank you very much.
Okay, thank you, Dagny. And I was wondering if Kathleen would like to go next.
Sure, I'm just gonna do the sharing of,
No.
hold on here, just a sec. I'm gonna try toggling back and forth. It went pretty smoothly. Okay, if I go into slideshow, let's see. Is that showing full screen? Yeah, okay.
Great.
All right, so yeah, so I'm an occupational therapist and I'm here to talk about occupational therapy in rural or remote settings. I've included my contact information. I'm always available for people to reach out if they have questions or concerns about anything around OT and how to access it in your own communities. So in terms of my own background, I grew up in Edmonton, but I did move to Ontario and completed my degree from Western University in occupational therapy in 2004. I personally am based in London, Ontario, but I travel throughout the province. I'll show you in a moment some of the areas that I cover in the work that I do. And so I'm a community-based occupational therapist. I've worked pretty much exclusively in the community since I graduated 20 years ago. And so I work with anybody who ranges from school-age children all the way through adulthood and into the seniors. So the areas that I personally cover and have worked in so far have included areas as far north as Port Elgin, Southampton, all along Lake Huron here, so Kincardine, Goderich, Grand Bend, Sarnia, all the way out to Windsor and down along the north shore of Lake Erie, Simcoe. I have gone out as far as St. Catharines, but that was kind of a unusual, kind of a one-off client. Brantford, Kitchener, Waterloo, and Cambridge for sure. Going up along Listowel, Hanover. And I've also been up in further north in Thunder Bay and Red Rock last summer doing some assessments for medical malpractice files. And I also, when I was doing my own personal clinical placements back when I was a student at Western University, I chose to do a placement up in the north of Ontario. So we were based out of the Timmins Community Care Access Center. So that was like publicly funded community health care. And we also traveled out during my placement to Kapuskasing and Hearst, which are some of the areas out in that area. So occupational therapy is, I'm just going to try and, I'm going to try and reduce that so that you'll be able to see. So occupational therapy is a field that many people don't have a strong understanding of until they've actually had an opportunity to use our services. But essentially the word occupation is not just restricted to work settings. So like occupational health and safety, generally people think of as being like a workplace safety program. But in occupational therapy, like our professional understanding of what occupations can include, that can include self-care, so taking care of yourself, getting dressed, having a shower, feeding yourself, productivity, which could mean going out to work, could mean doing things that you need to do around the house, like yard work, housework, volunteer, leisure, so activities that you do for fun, and taking care of others. So those are some of the things that occupational therapists can get involved with. So if you've ever had an occupational therapist, or if you have a reason to have an OT working with you, then usually that would be because you're having some difficulties completing any of those kinds of activities. So we tend to focus, whereas like physiotherapy, and as Dagny did a great job of explaining about how physiotherapists tend to be very hands-on, looking at an individual person's injured tissues and trying to kind of bring those up to maximal function. Occupational therapists are looking more at the bigger picture. So we tend to take a step back. I don't tend to do a lot of hands-on work with my OT clients, but I do look a lot at what their limitations are. So that would mean the person thinking about what are their physical, their cognitive, their emotional difficulties, what kind of environment are they needing to do activities in, and what are the activities that they need to get done. So what kind of health conditions OTs can treat? I just pulled this off of the Ontario Society of Occupational Therapists website, but could be anything from acquired brain injury, amputations, anxiety disorders, low vision, all the way through to spinal cord injury, stroke. In terms of my own background, most of the clients that I work with have included clients who have chronic pain, orthopedic injuries. I've worked with people who've had hand injuries and needed splints. Also mental health issues like depression or PTSD, anxiety, concussion or brain injury, low vision, autism or developmental delays, spinal cord injury, and amputations. So pretty wide range of different kinds of health issues that I have worked with personally. And so if you were to see an occupational therapist, where would they be meeting with you? Well, they might meet with you at your home, or if you were residing in a long-term care facility, they might come out to see you there. They might also work with you in hospitals or clinics while you're receiving other kinds of care there. They might come out to see you at school or in your workplace, and also at different locations in the community. Like, for example, some of the clients I work with, I might take them out to problem solve around some difficulties they might be having with grocery shopping. So I might be going out with them out into the community and doing some grocery shopping with them. Or I might support them at government offices, like getting a health card renewed, or taking them to a doctor's appointment and making sure that they have somebody who's a well-informed advocate on their team who can, basically provide some good detailed communication and relay that onto the team about what's going on with a particular situation that the medical appointment was arranged for. So in terms of access to OT, so similar to Dagny's different streams of funding that can help out with situations that involve physiotherapy, some OT services are covered by OHIP. There's also various kinds of insurance that might be involved. So a lot of the clients that I work with have either been in a motor vehicle accident, so there's insurance on that side that pays for my services, or WSIB if they've had a workplace related injury. Some of the clients I work with also have just extended health benefits through their employer, and they might need some supports to help them manage through those that stream of funding. Employers, so some employers feel like it's just good business for them to make sure that their workers are well taken care of, and that they might ask me to come in and do an ergonomic assessment for a number of their workers to make sure that the work site is as healthy as possible and everybody can perform their tasks as smoothly and easily as possible. And sometimes people just pay out of pocket because they have a particular issue that they really want to address with myself. So an initial assessment that an OT would do would be looking at a person's physical functioning. We also will address cognitive functioning. So how is somebody thinking? How's their memory? Are they able to problem solve decisions, make decisions in an efficient way? And how's their emotional function and regulation? We would also potentially look at what's the client's home, workplace, or school environment looking like. You know, is it well set up to meet their needs, or is there something that can be improved on that side? And looking at the activities that need to be performed. So we're looking at the activities that a person wants or needs to do in that environment, and how well are they able to do them or not. So basically kind of problem solving on that functional level on how somebody's managing day to day. So the assessment, if we've done a good job of our assessment, it should answer the question, what tasks are difficult that this person wants or needs to do? Why is it difficult if there are problems, and what would help? So in some cases, what we would be looking at in terms of treatment is always going to be very individualized. We would be looking sometimes at providing equipment. So it might mean providing a bath chair to help somebody get in and out of the shower, like a bath bench. If somebody can't weight bear and they need to be able to get in to be able to shower, but they have a broken leg, it could be something just like a more comfortable, well-fitted, ergonomic work chair for them. So I'm looking at getting delivery and installation by local vendors. Not all of the clients that I work with are going to be serviced by London-based vendors where I'm coming from. And so I'm going to be doing research when I go out to see clients to find out what are the local companies that are available to do equipment installation, rental, and retail. I might also be providing some coaching and education on strategies to manage their symptoms. Sometimes we provide programs, either exercise that could be physical or cognitive, setting goals for daily activities. And I'm also going to potentially be recommending other local services. So maybe a personal support worker should be coming out and helping you with getting dressed in the morning, or maybe you should be seeing your local physiotherapist. So I might be recommending to somebody, if they don't already have a physiotherapist on their team, I might be making that recommendation, or referring on to speech pathology if there's cognitive issues or feeding issues. There's other team members as well that sometimes we refer to. So within a rural setting, though, there's some things that are different about working with clients in a rural setting, because occupational therapists are really interested in the environment in which we do the everyday activities that we do. The kinds of activities that even get done by somebody living out in a rural setting might be different. So, for example, the actual rural occupations that I have seen clients be involved with, and that I've helped them to potentially get equipment to help them manage more effectively, include things like farming tasks, hunting, trapping, fishing, boating, horseback riding, dirt biking, snowmobiling, ATVing. All of those tasks are not necessarily the kinds of activities that people who are living in the city would have access to. So there are definitely some different occupations that I'd be looking at within a rural setting. One of the earlier things that I put on that slide was also the fact that I do need to consider travel time and frequency of sessions. So if somebody is going to be, a 3-hour drive or a plane ride for me to go and visit, is there funding for me to come out and see them? Do they, how often would we reasonably be able to meet? Are there some virtual options too? Like once I've done the actual in-person assessment, sometimes I can do follow-up sessions virtually and get the local vendors to do the delivery and installation of the equipment. Other things that are involved in thinking about rural setting, clients living in rural settings, are like, what kind of social supports and distances are involved? Somebody in, a city setting might have a family member or friend who lives in the apartment building right across the hall, whereas you know, in this situation in a rural setting, somebody might have their adult child or daughter who lives up the road, but it might still be a 45-minute drive. So obviously there's a different level of support that you'd be expecting when somebody has those kinds of distances that they're dealing with when it comes to daily supports. I need to find out who the local vendors are who are providing equipment or services. What are their skills? How soon can they make it up to this given location, given that, you know, travel time that might be involved for them as well? And what are some other local service providers and therapies that are available in that particular center? Given that I'm just kind of coming in from the outside, I really need to connect somebody with their local supports. Larger properties certainly need more time and different equipment to manage. So like for somebody in the city who has a little postage stamp lawn, you know, an electric battery operated lawnmower might do the job. But for somebody, for example, who's living on the rural property, like you see in the photo, you're going to need a riding lawnmower at the very least. And, you know, a bent handle ergonomic shovel is not going to do the job for clearing that kind of driveway. So, and also another issue that does come up is just around transportation and ability to drive. So what do we do to support clients who want to continue to live in their homes in rural areas, but where they, you know, may have limited access to transportation and maybe they're not medically eligible to drive anymore. So there's some hard conversations that sometimes come up around working with clients who are living in these areas a bit more isolated and who need to be able to get around. So anyway, that's basically all that I have to talk about for now. So thank you very much, and I'll pass things over to Lauren.
Thank you, Kathleen.
Oh, sorry to interrupt, Lauren. I think you're on mute.
There we go. Okay, Zoom went away on me, so there we go. Okay, thank you for that. So as I was introduced, I'm Lauren Summers. I'm a speech and language pathologist. I have a very unique career. So I'm just going to kind of walk you through that today. So just briefly about me, I am from Bayfield, but I currently reside in Seaforth. I've obtained my bachelor's in speech and language sciences from Brock, as well as a master's in speech language pathology at McMaster. And I currently work as a speech language pathologist with 2 companies or organizations. So SpeechWorks is my employer. It's a private practice based in Burlington, but we are contracted by Sioux Lookout First Nations Health Authority, or SLFNA, to provide SLP services for both pediatric and adult clients in remote regions of Northwestern Ontario. So briefly, to describe the role of an SLP, we are allied healthcare professionals in the rehabilitation field that work with people of all ages to assess, treat, and diagnose many different types of communication and swallowing disorders. So if it has anything to do with their ability to eat and swallow food, or to be able to communicate, whether that's to understand what people are saying or to be able to express themselves, our role is there. That's where we kind of come in. So some of the areas might include speech sounds. So whether that's someone who has difficulty with articulation, it could be a kid who's struggling to say their L's and R's or their S's, like what most people think of us as. Or it could be someone who has ALS and is struggling with dysarthria and slurred speech. So we can work with patients and clients with those disorders, along with language-based disorders. So whether that's acquired from a stroke and they end up with aphasia or the loss of language, or developmentally, they might be behind their peers when it comes to their receptive and expressive language, their ability to understand and be understood, as well as social communication. So the effects that their ability to understand some of those higher level communication skills like jokes and sarcasm and being able to know what's appropriate, what's inappropriate, or what I like to say is expected or unexpected communication behaviors. We also work with voice, so whether that's people who have lost their voice, people with vocal nodes, people who have resonance issues, so airflow is coming out their nose versus their mouth, which can distort how their voice sounds. We work with kids and adults with fluency or stuttering disorders, as well as children with literacy impairments, because written language is still language. It's still a form of communication, so that's why literacy is within our scope. Oral rehabilitation, so people who may lose their hearing or have never had their hearing, being able to navigate that and being able to be effective communicators in any way that they can be, or if they've received their cochlear implants or hearing aids, we help them be able to make sense of the sounds that they're now experiencing for the first time. And then there's alternative and augmentative communication. So those are like communication devices. People may not be able to speak using their voice. And so these are assistive devices that they can use to be able to communicate for them. And then there's cognitive communication, which if someone has an acquired brain injury, most notably a traumatic brain injury, it might affect their ability to organize their thoughts, their executive functioning might be impaired, memory might be impaired, and communication might be impaired. So we help with those sort of cognitive skills, along with feeding and swallowing. So both for pediatrics and adults. I've worked with infants as young as 6 months of age and adults as old as 99. So there's a huge range there. And other areas such as accent modification, that's just a volunteer service. We don't think that accents are needed to be corrected, but some people do come to us to assist with being able to modify their accent so that they are better understood by other people who may not be familiar with their accent. Along with working in the legal sector, I'm a communication intermediary. So oftentimes I will work with the court system to provide an easier way for people who are either defendants be able to understand what it is that the lawyers are communicating to them in an effective way. So lots of things that we can work with. And then these are just some examples, just so you can visualize it. So this is what I mean by assistive devices. It could be someone with ALS who has lost their motor function, lost their ability to speak, and now requires a system using eye gaze to be able to communicate. Or it could just be something as simple as a cord board where a child might be able to point to certain pictures or build certain sentences to help get their messages across. We can run things like aphasia groups. So for older adults or even young adults who have had a stroke and have aphasia, we run these social groups to allow them to be able to practice their skills and their strategies and to strengthen those connections in the brain to kind of get some of that language back. And then we also work uniquely with gender affirming voice as well. So helping people with that gender dysphoria that they feel, be able to produce a voice that best matches their gender. And we work in a variety of settings as well. So these are some of the most common, whether that's schools, long-term care facilities, private practice, hospitals, in both acute, NICU, or long-term departments. But we also work out in the community as well. More specifically, I work in the First Nations communities, and I'm kind of an everything SLP. So I'm required to go into the schools and provide school service, but I'm also required to go to the nursing station and provide service there, or I might go to the homes and provide home care service, or I might have them come to a healthcare community building separate from the ones that I've just mentioned to receive service. So we just kind of make do with what we can and do the best that we can with the resources that we have. So I just wanted to walk you through a day in a life of what it looks like for me when I work in the remote First Nations communities. So I work specifically in 6 communities, but I help coordinate services, speech services for 33 communities in Northwestern Ontario, including Sioux Lookout. But the 6 communities that I oversee for SLP services on a consistent basis are Weagamau or North Caribou Lake First Nation, Webequie First Nation, it's a long name, Kitchener-Mekusub and Innuit, or KI for short, and Sachiko Lake, Cat Lake, and Bearskin Lake. And I've highlighted them here on the map. So you can see they're pretty far north, in the middle of forests and lakes. And then this is just a picture of what that looks like. So I've labeled them here to give you a sense that all communities have some things in common, but they're all different. So they're all nestled next to a large lake that provides support for things like their winter roads. When it freezes over, it allows them road access to and from other communities. Fishing, it allows them just an access to trade. Originally, it had something to do with trade, the government. So they put these settlements, these reservations close to the water so they could access them effectively for things like trade. And yeah, they're very small, very close-knit communities. They're not in large areas whatsoever. Webequie is on a small little island. I can walk from one end to the other in less than 30 minutes. So very close and tight-knit. So as I mentioned, I work in schools, I work in the nursing stations, homes, community healthcare buildings. I train community members to carry out SLP therapy techniques. I build relationships and trust with people. I take part in cultural activities, collaborate with members in the community as well as other clinicians. And I do so much more that I just can't put into words today. So for example, you'll see here that we take these really small planes. The communities I travel to are only accessible by plane, except for in the winter, they are accessible by road through the winter roads. I've been on them, they're really scary, but safe for the most part. So we take these really small planes to the communities. We take part in events like here I am frying some French fries for the Education Authority's end of year celebration. I take part in traditional activities like learning how to prepare hide for various uses like making drums or rattles. I go into the schools. I take part in things like Orange Shirt Day or Truth and Reconciliation Day with the whole community. I take part in sweat lodge ceremonies, which are interesting. Sometimes I'll spend my evenings supporting the clients on my caseload and kids in general at their local arenas to watch them play hockey or broomball or anything like that. And when the season is right, I also go out and do what I can to pick some blueberries. Best blueberries I've ever had. We'll never experience anything like that in your local grocery stores. So some of the benefits of my role, it provides an opportunity for continuous learning and growth. Each community is different and unique, and it allows me to build unique connections and opportunities to integrate myself with the community and the events. I get to speak with a lot of the community members and elders to hear their stories and to learn more about their community. And I've spent many hours speaking to parents and grandparents about their perspectives, which greatly informs my practice. So a never-ending learning journey. It also allows me an opportunity to spread awareness and destigmatize First Nations populations, and to kind of let them know what it's like to live and work on a reserve, opening up to new perspectives and decreasing some of those stereotypes that we might have around Indigenous populations in Canada. It allows me to own in on my flexibility skills. It provides a supportive environment. The work I do is very meaningful and impactful. I've got unlimited opportunities. It's always a sense of adventure, like going on helicopter rides, ice fishing, taking part in hunting activities. And yeah, I get to work with many, many fantastic clients, their families and coworkers. And it really does cater to my ADHD brain because everything is always new. It's exciting, it's ever changing, and nothing is ever the same. So I really love that part about my job. But I can't speak about the benefits without talking about some of the issues. Quality of service is subpar. I only go in once a month for a full week, and it's not the intensity necessary to see true growth and change if you're working on one-on-one. The service isn't consistent. I try to make it as consistent as possible by offering virtual services, but unfortunately, not all communities can support virtual services. They may not have the internet infrastructure to be able to have those sorts of services. Infrastructure is lacking. They don't have the funding, they don't have the resources, the housing, things like that to kind of keep people in the community. So we're always having to travel in and out. There are high burnout rates with a high workload. It is what it is when you're only there once a month for a week. There's a lot that you have to try and do within that time frame, and then also outside of work. And unfortunately, there aren't as many incentives to try and stay in the area. I lived in Sioux Lookout, but unfortunately, due to family, I had to come back to Huron County. And yeah, it's really hard to kind of stay up there and live up there, housing shortages, things like that. And there are high caseloads to low SLP ratio. So I have a caseload, I'm one SLP for 150 kids per community that I travel to, and that's not including the adults. So it's really hard to do your job when you have so many people who require your services, and there aren't many of you to go around. And what's really frustrating is research conducted about 1 to 3 decades ago is still applicable today, in that there's a call for this altogether different approach. Things aren't working. There's frustrations with the system. And unfortunately, after having read the research, I still feel it, like it's still applicable today, but my team is working really hard to try and change that. Okay. And with that being said, I'll just wrap up the presentation there. But here's my contact information if you do have any questions or want to know more about my role. I'm happy to share. Okay. And I just need to figure out, there we go.
Okay, thank you very much, Dagny, Kathleen, and Lauren, for sharing that information. The services and treatments each of you provide can be remarkably life-changing for your clients of all ages. I have a question about time sensitivity of your treatments. Just wondered if each of you could address, for instance, starting with Lauren, is there a particular age when clients benefit most from speech therapy? For example, how critical is it for a client who's suffered a stroke to begin speech therapy right away to ensure long-term success? And similarly, Lauren and Dagny, how dependent is the success of your treatment on really early intervention following an injury or surgery?
Yeah. I can start. So for children, the critical period is really 13 and under, but if you really want to make the most gains, the earlier the better. So early intervention services for children who are 5 or 6 years or younger is beneficial and necessary in order to see lifetime change and successful progress. 13, the reason why I say that is because research shows that at that point, the brain is slower to be able to learn and has a smaller capacity to learn things like language. And so we try to get a lot of the skills developed before that age. And likewise with aphasia, when it comes to communication, we want to try and hit them before the 6-month mark post-stroke. That first 6 months is critical. Specifically, the first 3 months post-stroke is necessary in order to help try and make the most gains that they can. Not to say that after that 6 months they can't make gains. It's just usually slower.
Thank you.
So as far as injuries go for physiotherapy, it's so injury dependent. So some injuries in the acute phase, you're not actually doing a lot. So there'd be much more education for those clients, regarding sort of gentle range of motion, maybe some icing, keeping some muscles firing, and trying to get some cardio going if possible. So it really does depend so much. It's a hard question to answer. Some people you'll see initially when it's an acute injury and then not see them for a couple of weeks because you've given them what they need to do to allow them to get past that acute phase. But then if you're thinking of something like a total knee replacement, people have to be on it as soon as surgery is over with, because if they don't work very hard in that initial 6 to 8 weeks, then they're not going to get the function back that they really would like to after their total knee replacement. So it really is very dependent. But then there's always hope, even if somebody hasn't gotten treatment initially, and maybe they should have, you can always make a difference no matter what the injury is, because you can always educate the person on different ways of moving or different muscles that maybe they're not, if it's a knee problem, maybe they need more strengthening in their core or their hip area to make their knee better. Maybe you can't change the injury that's happened to their knee, but you can change the surrounding tissue and the other joints that are so, dependent, because they all work so well together and one needs the other. So you can always find a way of making a change for a person, no matter how long they've had the injury for. And, to speak to that, actually, if you're thinking of something like Parkinson's or MS, and there is no cure for that, but you continue to work with somebody, even if they're slowly changing over time, you're still working with them so that they can have the best life possible at that moment in time.
Thank you. Anything to add to that, Kathleen?
Sure. Yeah. So occupational therapy, we're a little bit in a different situation in the sense that sometimes, like as opposed to physiotherapy, we can get involved really, like as a community OT, I can get involved as soon as somebody who's already admitted as an inpatient is ready to consider being discharged home. So in many cases, they are relying on the occupational therapist to come in and assess the client, go to the client's home environment, look at the home environment and see what kind of equipment do we need? Do we need a walker? Do we need a raised toilet seat, a temp transfer bench? What needs to be in place? And the hospital is actually waiting for me to get all that equipment in place and get the personal support worker coming in to help them out with their bathing and showering and, meal prep, so that they can free up that bed, so they can send the client home safely. So that is absolutely the most time sensitive kind of assessment that an occupational therapist would typically get involved with, at least in the community setting. So yeah, generally, like we get the referral and within about 2 business days, we need to have gotten in there, seen the client, gotten into the home, set everything up, arranged for the equipment delivery and the medical transportation, even to get them from hospital back home. We set it all up and then they can free up that bed. So there's a lot of time pressure on that side. Once clients are, operating in the community, then there's a little bit more like breathing room for us to kind of do what we need to do in a little bit more of a manageable time scale. But you know, for somebody, for example, who has an acquired brain injury, generally if we're going to do cognitive therapy to try and actually bring back some of their cognitive processes, usually the first 6 months to 1 year is like the most important in terms of like really consistent and active intervention. If you miss that window of time, then you do kind of, and I think it's similar for stroke as well, although I don't work directly with stroke as much, but you know, there's a window of time during which people can achieve the most benefit in terms of being able to get back to their pre-incident level of functioning, or as close to it as possible. After we've passed that window, OT can still be involved, but will not be working on actively doing exercises to try to remediate. What we call is like a remediation versus compensation. So early stages, you're going to work on drilling some of those processes, or trying to, like, sort of like a physiotherapist would be trying to like strengthen a muscle. We'd be trying to work on those cognitive processes. Once we get past the 6 to 12 month range of, then generally we're moving more towards compensation. So given the fact that you do still have some difficulties with your memory, what are some strategies we can get in place? You know, maybe we can start relying more on smartphone reminders, and maybe we can put some organizational equipment in your home, like a whiteboard, or some places to put your mail, like a system, so that you see the mail when it comes in and the bills that get paid get filed. So you kind of do sometimes help people build strategies that will, once you're past that early stage. When it comes to children too, there is certainly evidence that with certain kinds of conditions, earlier intervention is better. So, you know, if somebody has like a developmental delay, or even like when I was working in the school health program, I worked with a lot of kids who initially in my early career who just had fine motor delays. And early intervention for sure is more impactful for these children than waiting, you know, a few years down the road and seeing that they're still struggling, and at this point they've already maybe lost out on some school participation opportunities as well. So they're kind of, you know, they're not keeping up with their peers, and the gap tends to widen if there isn't the same level of intervention provided early on.
And I was going to say too, like for speech, progress is also measured by the intensity in which we can provide that service. So me being able to see a child or an adult for on a weekly basis is going to see faster progress and change than me being able to go into community and see that child for a once a month session. And so oftentimes, if I can't provide the level of intensity required to see progress quickly, I often will resort to augmentative supports, such as a communication device, to help offset some of the challenges they're facing being understood verbally. So.
Okay, thank you. Referring to a question in the Q&A, is there a way to refer to OT or speech language therapy in private practice from the ED, emergency department, I suppose, or does it go through the LIN or during hospital admission?
I can speak a bit to that. I think it depends a bit on the mechanism of injury and again, what other funding sources are involved. But I have personally, you know, worked with clients who were inpatients in hospital. Generally, they have been, you know, maybe on like an orthopedic trauma unit or a neurology like trauma unit rather than emergency department. But there's no reason why they couldn't, you know, if that kind of insurance is available, and you know a private provider is preferred, as opposed to like the LIN, which well, it's called, I think, home and community care now, but the government funding agencies generally have longer wait lists. They generally have a more scaled down availability of resources that they can offer. So if somebody needs something more intensive and it needs to happen like immediately, there's no reason not to reach out. It just means though that in that case, there would be like the LIN is more convenient because you can contact the one representative in the hospital who's going to like field that referral onto all of the home and community care publicly funded agencies. Whereas if you're dealing with private insurance, you need to be willing to reach out to individual clinics really and see who has something available. So often, you know, there's a discharge planner who's on the floor who knows, like they have a list of people who are prepared to work with clients, and they'll direct them to like they might reach out and say, I have this referral, and absolutely, you know, we can get involved right from the beginning when they're in the emergency or other parts of the hospital.
Okay,
And I
well,
was gonna say, like similarly for me, I do work a little bit privately on the side from my other jobs, and I do get some who are discharged from the hospital and they are in long-term care homes, and they're looking for private care because they don't have the level of support for speech in the long-term care homes, at least in the ones that I've gone to in Huron County. And so oftentimes I'm making my way through my rounds through the long-term care homes to just kind of educate them on our services and what a speech therapist could do, and that they know I'm around in case they need to refer to me for whatever reason. Just because I know speech therapists working with adults specifically in Huron County are far and few between. There aren't as many jobs as you would find in a city setting. So
okay.
yeah, it varies, but community care there is helpful.
All right. I can't believe how quickly that hour went by. And I do have a few closing comments I'd like to make, so I'm going to kind of rush through those. It's been very enlightening, so informative, hearing about the incredible work that you as our guest speakers do as healthcare practitioners. You assess, diagnose, create a treatment plan that facilitates a patient's recovery. You help people to resume and maintain participation in a variety of tasks in their everyday lives, tasks that the rest of us may take for granted every day. So a huge thank you to our presenters, Dagny, Kathleen, and Lauren. We'd also like to thank our wonderful sponsors for their continued support. Without them, this lecture series would not be possible. Thank you to McGee Motors, Goderich, Hurontel, DeJaegars Town Square IDA Pharmacy, Goderich, CIBC Wealth Management, Libro Credit Union, and Tuckersmith Telecommunications. Gateway Center of Excellence in Rural Health is a not-for-profit organization with charitable status, and we greatly appreciate and welcome any support we receive. Please join us for our next lecture. It's on December 3rd, noon hour, when Dr. Sarah Newberry will be discussing the challenges of rural recruitment and retention of our workforce. Thank you again to our panel, sponsors, and especially you for tuning in. See you next time. Bye, everyone.